Hi everyone, I'm Mehdi Merdani. In this video, we are going to break down the life-saving angioplasty procedure on this patient's L6 and LAD arteries, covering every technical detail step by step. The 82-year-old patient you see here was rushed to the cath lab with a diagnosis of MI. At the first glance, one of the major arteries appears completely occluded. Considering the patient's age, we are dealing with a critical and high-risk case. Let's dive into the diagnostic angiogram. In the first injection, the arteriocaudal view, we can observe that the L6 is occluded, right at the bifurcation point. Moving to the arteriocranial view, if you look closely, there is a significant lesion over the 70% stenosis in the LAD, just after the diagonal branch. To get a better look, we switch to elevocranial view, where the severity of the LAD stenosis becomes much more apparent. Finally, in the spider view, we notice that the proximal LAD is slightly ectatic. For this specific segment, we've decided on a medical management for now. With the left system analyzed, let's check the right coronary artery or RCA. As you can see, the RCA shows only mild intimal plaque, which are not critical. We will keep these vessels on a medical management as well. So our strategy is clear. We needed to immediately prepare the PCI equipment to recanalize the L6 and treat the LAD. We begin by wiring the L6. Then, using an appropriate sized balloon, we perform predilation just distal to the bifurcation to open the path. Here is the critical part. We must size and position the stent precisely to ensure we don't compromise the follow to OM branch. We inflate the stent and there it is. Look at the result. Blood flow is fully restored in the previously occluded vessel. Before we move on to the next vessel and crucial post-dilation technique, if you enjoy analyzing real-life angiography cases, make sure to hit that subscribe button so you don't miss our upcoming breakdowns. The vessel is open, but we are unfinished. To ensure optimal stent position, we must perform post-dilation. A key technical tip I always emphasize: during post-dilation, the balloon markers or dots must never be positioned outside the stent edges, as this can cause edge dissection in the healthy vessel wall. And here is the final result of L6, showing the excellent expansion. Now we take the LAD. First we wire the vessel, followed by predilation with a suitable balloon under the lesion starting just after the diagonal branch. Next, we position the stent to cover the entire lesion length. After confirming the position with a few check injections, we inflate. As you can see, the LAD is now widely patent. Finally, to ensure perfect position, we perform multiple post-dilation with precision. Here is the final angiographic result. A patient who presented with an acute MI now has restored blood flow in both major arteries and is hemodynamically stable. Thank you for watching.